So I know I'm picking up the end of a long day here. I'm not going to be as entertaining as Dr. Susky was. That was great. But what I want to start off by thanking Susanna and the Community Liver Alliance for asking me to come and speak to you here today. I was asked to do something very simple, to basically give a case presentation, sort of as a cap note for the day, which today focused on autoimmune liver disease. So when I was asked to do this, there was a patient who came right to mind who has been on a saga with me for a little over a decade now. One could literally learn all there is to know about autoimmune liver disease from this particular patient. I put the slides together. I realize we have an audience of a varied background in terms of familiarity with the medical world, and I put my talk together. In the idea of speaking to like a medical resident or mid-level provider. So bear with me. If anybody has any questions, please stop me right at the moment and just ask me to clarify. But I will try to present this. So this is a patient. If you have any, most of, if not all of you, have some background with autoimmune liver disease. This is really a pretty fascinating case to me, at least. In what we went through, the travails in getting this patient into a really good place at the end. Rest assured, number one, this has a happy ending, and number two, if you know anything about autoimmune liver disease, you're going to think I made this stuff up. None of this is fabricated. This is all true story. So my patient is a 54-year-old Caucasian female. She has a history of asthma, peptic ulcer disease. She has rheumatoid arthritis, is under the care of a rheumatologist, and has been on Enbrel since 2010. She had no surgical histories, never had surgery. She had small polyps taken out of her colon a couple years before. She's not a cigarette smoker. She does not use alcohol. She has never used illicit drugs. She is married. Her husband has no history of liver disease. And in her family and her blood relations, her mother has MASH, which is the term for, it's the term we currently use for fatty liver disease, okay? So metabolism dysfunction associated steatohepatitis, MASH, like the TV show, right? Otherwise, the family history didn't add much to her history, no other clues there. She's not allergic to any medications, and she takes a few medications, but nothing that's liver toxic. She takes an Advair inhaler, Atarax every now and then for seasonal allergies, Naprosyn every now and then for arthritis, and Protonix or pantoprazole for acid reflux. So nothing comes to mind as being a culprit liver toxin. So she didn't come to me until, she originally came to me about 10 years ago. She presented initially to her local gastroenterologist back in 2008. She first joined the GI community, was found to have an elevated alkaline phosphatase. Okay, alkaline phosphatase, or ALK-Phos, is a liver enzyme. All right. So for those of you who are not familiar with liver enzymes, alkaline phosphatase, AST, and ALT make up part of our usual liver panel. AST and ALT elevations are usually indicative of liver cell injury. Okay, this is going to be important later. AST and ALT are usually indicative of liver cell injury and typically are what we see elevated in a hepatitis, whereas alkaline phosphatase elevations are typically reflective of problems with bile flow. Okay, so what we call cholestatic liver diseases. So her alkaline phosphatase for a while had been hovering in the 250 to 300 range. Normal is generally about 104, 110 or below. So this is a 2 to 3 time normal alkaline phosphatase, and it had been hovering at this high level, about 2 to 3 times normal, for somewhere between 6 and 12 months before her presentation. So this is clearly chronic. This is not a fluke. This is not something going away. And when she showed up, she just had lab abnormalities. She didn't have any symptoms. She didn't come to the doctor complaining of anything at all. And they did a little bit of workup. They did start looking for different liver diseases, like they tested her for hepatitis C, because common things are common, and they tested her for ferritin and transferrin saturation, which are tests we use to screen for something called hemochromatosis. So similar to Dr. Susski's disease, where you build too much copper, hemochromatosis, you store too much iron. And these cause hepatitis. But of course, this doesn't look like a hepatitis. But importantly, she has a positive anti-mitochondrial antibody, or AMA, okay? And that's very key in this disease, okay? So they ended up doing a liver biopsy, but in the real world, they didn't need to, and I'll show you why. But a liver biopsy was done, and she had these changes, okay? Chronic portal inflammation, okay? So inflammation around where the bile ducts and the blood vessels flow. Florid duct lesions, which is a very characteristic hallmark of this disease, PBC. Okay, it's where your bile ducts, when you look at the liver and you look at the bile ducts are being attacked by inflammatory cells, injured, and eventually destroyed. Granulomas. Granulomas are clusters of white blood cells and also fairly characteristic of PBC. There was a little bit, not too much ductopenia. Ductopenia is where you start losing bile ducts. So where you look at the liver biopsy and you look where the bile ducts are supposed to be, you're not seeing them. And in PBC, progressive ductopenia is a characteristic feature. So this sounds like it's kind of early. There's not too much ductopenia. She has stage 1 fibrosis, very early stage. Stage 4, again, just for orientation, stage 4 is cirrhosis of the liver. 3 is less than that, 2 is less than that, 1 is less than that, 0 is none, okay? So she just had stage 1, and she was diagnosed with PBC, okay? Now, this is what her liver biopsy looks like, and I don't have a pointer, but right in the middle, you see a kind of clear space over there. Well, that's a bile duct, and bile ducts are usually very nice, regular, round structures. Square cells making a nice lifesaver looking thing, and you can see that this is irregular, it's jagged. The normal bile duct cells are not making a nice complete circle, so this is very typical. This is the portal area, and you see all those blue cells. Those are your inflammatory cells. So it's a chronic portal inflammation. So this biopsy fits very well with the diagnosis of PBC. Okay. Now, according to the AASLD guidelines, last published in 2018, you can make a diagnosis of PBC when you have 2 of the 3 criteria. Okay. So a chronic alk phos elevation, a positive AMA, or a liver biopsy that's consistent with the diagnosis. You do not need all 3. You need 2 of those 3. So when she first presented with the chronic alk phos elevation, the positive AMA, she's a middle-aged Caucasian female, which is 90% of patients with PBC, okay? So she met the diagnostic criteria like this, okay? But the liver biopsy certainly put the nail in the coffin, right? So PBC can progress. It's generally a slowly progressive liver disease, and it can progress all the way to cirrhosis, like any other chronic liver disease, okay? So your PBC stages, stage 1 is very early. There's some inflammation and florid duct lesions like I showed you on the biopsy. Stage 2 is when you start building up fibrosis in those portal areas. The bile ducts start to do weird things and proliferate. And then as the scar tissue builds up, you get bridging fibrosis, which is more advanced. And then stage 4 is cirrhosis of the liver, okay? Now, this can be a tricky disease to diagnose because many patients have no symptoms. Many patients present with just the alkaline phosphatase elevation, okay? But when patients do present with symptoms, the most common are going to be fatigue and pruritus, which is itching, okay? Pruritus is itching, and that's not uncommon at all. On physical exam, you can see xanthomas, these little yellowish bumps around the eyes, which are sort of cholesterol collections. Sicca syndrome is the dry mouth and dry eyes that are not uncommon. Early bone thinning, okay? Patients with cholestatic liver diseases like PBC can develop early bone thinning. And then portal hypertension, which is pressure backing up behind the liver that causes all kinds of problems, that can be seen. It's often seen in the later stage diseases, the later stages of disease, but sometimes because of the lack of symptoms, patients aren't diagnosed until very late. And then it's an autoimmune disease, and like any other autoimmune disease, if you have an autoimmune disease, you're statistically more likely to have others. and your family members are more likely to have autoimmune diseases. And the weird thing is it may not be the same autoimmune disease. It may be PBC in mom, and it may be thyroid disease in the sister, and it might be celiac disease in the cousin. So it's a very mixed bag. Yes. I'm sorry, hypertension. Portal hypertension. High blood pressure in the portal circulation, which is, so when the blood leaves the abdominal organs, it goes to the liver on its way back to the heart. So when the liver becomes stiff, like from cirrhosis, it gets hard and shrunken up, and all the blood has, fights, there's more resistance for the blood to flow through the liver, so pressure backs up. And that portal hypertension is what leads to a lot of the complications you see in people with cirrhosis. Okay, sorry, but thank you. Thank you for the clarification. So first-line treatment for PBC is ursodeoxycholic acid, or URSO. It's weight-based dosing. And then we have second-line therapy. URSO is a good, very benign, very safe medication. Okay, it's an oral medication, and it works very well, but upwards of 40% of people don't have an appropriate response. So there are second-line agents that we have on the market now. We have 2 PPAR agonists that were just recently approved by the FDA in the past year. One is called elafibranor, one is called seladelpar. Now, we did for a bunch of years have a drug called obeticholic acid, or Ocaliva, but it was just recently withdrawn from the United States market. Okay, so these 2 that I have listed here are what are going to be our second-line drugs for those people who don't have an appropriate response to URSO, okay? But I want you to remember the obeticholic acid part, okay, because we're going to come back to that. And then some practitioners will use a type of drug called fibrates. They're usually for hyperlipidemia, but they actually help bring down the alkaline phosphatase. And some practitioners use fibrates, but it's an off-label for this disease. So the patient was started on appropriate first-line therapy with URSO. It's weight-based. She got 1,500 milligrams a day. She was started on calcium and vitamin D because she's at risk for bone thinning, and she does have a history of vitamin D deficiency. But she did have a baseline DEXA scan, bone density. That's a bone density scan, which was normal. Okay, so her alkaline phosphatase did come down. It came down to about 150 to 180, and we can debate about whether that's an appropriate response, because it's not normal, but it's a lot better than it was, and it does bode an improved prognosis when that happens. The higher the alk phos, the worse the prognosis tends to be. So her alk phos then remains stable for several years, but then it starts to rise. Okay, it starts to go back up to levels that you can see here, back up in the mid-200s, and there's a little bit of elevation of her AST and ALT. Wait a minute, that's a sign of a hepatitis. You don't usually see that in cholestasis, okay? But if you get a bad enough cholestasis, you can see a little bit of hepatitis. And if you get a bad enough hepatitis, you'll see a little bit of cholestasis. So that didn't throw us too much, but the rise in the alk phos to this level, that's not an acceptable level to sit on, okay? Her liver function, however, was still good, and her blood count was good, and her blood chemistries and her kidney function were good, and at this point, the patient was referred to me in 2016, okay? So, on presentation to me, she again had no complaints. She had a pretty unremarkable physical exam. She weighed almost 250 pounds, so she was overweight, but her mental status was normal. She didn't have yellowing of the eyes. She wasn't jaundiced. There were no physical findings to suggest cirrhosis. Her mouth was moist. She didn't have an enlarged thyroid to suggest thyroid inflammation. She had a pretty benign abdomen. There was no palpable enlargement of the liver or the spleen. Her extremities were normal. So a pretty benign physical exam, pretty benign clinical presentation, just some numbers we don't like. So we did do some additional workup because those AST and ALT are going up a little bit. Should we start thinking about another liver disease here on top of her PBC? Well, we did the AMA, which again showed a strong positive titer, again consistent with the PBC. Now she had some other tests, the ANA and the ASMA, anti-nuclear antibody and anti-smooth muscle antibody. These are autoantibody tests that we use to screen for autoimmune hepatitis. Okay, and she did have some positivity, but that didn't throw us because people with PBC sometimes have other positive autoantibodies. Okay, and she had a normal GABA globulin level. In people with autoimmune hepatitis, they usually have very high gamma globulins, and she did not. And there were some other autoantibodies that were sent that came back negative. She was tested for hepatitis. She already tested negative for hepatitis C. We tested her for hepatitis B, and what these results mean is she doesn't have hepatitis B, but she's immune because she got vaccinated at some point in her life. We tested her for hepatitis A, and that was negative. So we actually recommended she get vaccinated for A, and that worked, and she became positive and got immune. Okay, so she's immune to B, immune to A. We're protecting her from other liver diseases. We check her ceruloplasmin for Wilson's disease. Alpha-1 antitrypsin deficiency was tested for. These results came back normal. And then we said, maybe the alk phos is going up because there's a problem with her bile ducts. Maybe she's got a stricture, maybe she's got a stone, maybe she's got an overlap with this disease called PSC, which is an autoimmune cholestatic liver disease where you get strictures in your bile ducts. So we did this special kind of an MRI to look at the bile ducts, and that was normal. Okay, so we're thinking through all this stuff, and we're not finding a whole lot else other than PBC that's not working. So we repeated a liver biopsy. And the biopsy, to make it short, the biopsy basically showed the PBC changes we'd seen before, maybe a little bit more scar tissue at this point, okay? And there was a little bit of something called interface hepatitis. So what that means is the inflammation is not just limited to the portal areas, but it's starting to reach out into the tissue of the liver, okay? But it was very mild. But what we did see is she had a really fatty liver. So remember I said she was 250 pounds, she was obese, okay? Her BMI was over 30. So she had 40% of her liver cells were infiltrated with a lot of fat, and she had some things on the biopsy like ballooning degeneration and lobular inflammation. So some things to suggest she had fatty liver disease. I don't remember. I think it was 4. I think it was 4, if I remember correctly. She did have ductopenia, a little bit more than she had previously, so the PBC is still at play here. We may have a second liver disease now in terms of the MASH, the fatty liver disease, and they did stains for iron and some other types of stains to look for some other diseases and infectious problems, which came back negative. So we basically have ongoing PBC, and we have now MASH. We now have fatty liver disease, okay? So now we sit down to think, what do you do? What do you do now? So we did 2 things. At this point in time, obeticholic acid had been on the market. Okay, it wasn't when she first presented, but obeticholic acid or Ocaliva is now on the market, approved as a second-line therapy for people with PBC who are not responding adequately to urso. So now we add obeticholic acid. Okay, and for her fatty liver disease, we put her on vitamin E. And we talked about pursuing weight loss. We wanted her to lose about 10% of her baseline weight. Her baseline weight was about 250. That was her max. We wanted to see her come down a good 25 pounds. Okay? Now, obeticholic acid, for those of you who are not familiar, you start at a 5 milligram dose. You monitor them for about 3 months. And if you still don't have an appropriate response, then you're supposed to go up to 10 milligrams. Okay? So after the first 3 months of treatment, she successfully lost 10 pounds in 3 months, which was great. Her alkaline phosphatase was still pretty high, 301. Her AST and ALT were still mildly elevated, maybe a titch better. But because the alk phos is still high, we bumped her obeticholic acid to the 10 milligram dose. And we were kind of happy. We saw the alk phos initially, the next set came down to 228, but then everything went up. And the alk phos went back close to 300 again, despite this, okay? And the AST and the ALT are climbing despite her losing weight and taking vitamin E. And we were concerned about the Ocaliva, the obeticholic acid causing hepatotoxicity. So we temporarily held the obeticholic acid. Her LFTs got better, as you can see. Not perfect, but better. And then we tried her back again on the 5 milligram dose, and it didn't do squat to her LFTs. So we just stopped it altogether because we weren't getting bang for our buck. Okay? And at this point, she'd been through a lot. We've done a lot of things with her. we said, let's watch this, see what happens. And unfortunately, her LFTs, we're watching them, and we continue to see the slow rise. And the rise became pretty significant. So now the alk phos is up into the 300s and the 400s. And the AST and the ALT are now going up close to or over 100. So these are some pretty significant elevations. And at this time, now she comes in with symptoms. Now she's saying she's getting itching. And she does have some fatigue, which isn't affecting her activities of daily living, her ADLs. But she's getting symptoms now that are new that weren't there before. Okay? And we tried treating, now we approached the itching. We said, okay, now you're having some itching, let's try treating the itching. Okay? We tried some simple stuff like antihistamines, and that didn't work. And she tried cholestyramine, which is a bile acid binder, which really didn't help very much. She's still working on her weight loss, and she's still bringing her weight down, so that's happening in parallel with everything else, okay? I thought I'd pause quickly to talk about pruritus. So in people with cholestatic liver disease, one of the main presenting symptoms is pruritus, which is itching, okay? And there's a whole, we can do a whole hour-long lecture on on treatment of pruritus. But to put it in three simple forms, there's conservative measures, there's pharmacotherapy, and there's more what I would call investigational or experimental things. So conservative stuff for itching, antihistamines, super duper, okay? Take some Benadryl at bedtime. It gets worse in the evening. It gets worse when you're hot, when you're warmer. So we tell people use cooler showers or baths. Take a few of the blankets off. Don't bundle up so snug at night. And skin moisturizers, Vaseline Intensive Care, Aveeno. These can be very helpful. Okay? Calamine lotion works great, but if you slather it all over, you look like the Return of the Mummy, so we don't do that. So if the conservative stuff don't work, then there's a lot of drugs you can reach. Cholestyramine is what all the literature tells you is first-line therapy, okay? I think I've had one patient ever in 30 years who got better with cholestyramine. I don't think it works really well, but that's what all the textbooks, and that's what the textbooks tell you, and that's the right answer on the tests. But what I like a lot is rifampin. Rifampin is a drug. It's an antimycobacterial. But it actually works very, very well for itching and has a pretty benign side effect profile. Now naltrexone is an opioid blocker, which can work well because the itching seems to stimulate opioid nerves. Sertraline is Zoloft, which is an antidepressant, which may be helpful. Phenobarbital is an old seizure drug that actually may work well. I've used it a couple times in some very refractory patients. And there is this new drug, Odevixibat, which is it's an ileal bile acid transport inhibitor. So it's recently approved by the FDA for people with a disease called PFIC, progressive familial intrahepatic cholestasis, which is just PFIC, specifically for treatment of pruritus. And maybe those indications will get broadened. So it would be off-label for PBC right now, but something to consider. And then there's a lot of I won't belabor it, but there's a lot of things that have been used, largely published in case series, small case series that have been published. UV light can be helpful. So going to the tanning bed. Plasmapheresis, nasobiliary drainage, which is putting a tube down the nose into the bile ducts and draining all the bile out, which is kind of awful. Low-dose non-sedating propofol, androgens, Marinol, which is a THC derivative. These are a lot of things that have been experimented but not in standard use. But there's a lot of toys you can play with for your challenging patients. Okay, segue aside. So at this point, we're not crazy about her numbers. We got her on her urso. We got her on her vitamin E. She's losing weight. She really didn't have any response to obeticholic acid, which was the only second-line drug available to us at the time. So we had no other toys in the toy box. We haven't exhausted. So we repeated a FibroScan. Let's see if there's any signs of the disease progression. And what we're happy with is that 9.3 kilopascals, that's suggesting stage 2 fibrosis. So as the years have been going on, she really hasn't seen much progression in her fibrosis. She still does not have advanced liver disease. And that 241 is a CAP score, which is a measure of liver fat. And this is a very low number, suggesting she has actually reduced or regressed the liver fat. So that's great, okay? And we added rifampin for the itching because the basic stuff didn't work. And actually, the rifampin worked great. Her itching went away completely. So that worked. We gave 5 milligram Ocaliva one more try because the PPARs weren't on the market yet, didn't do a whole lot, and we finally said, kaput, we're not messing with that. We stopped it and have not circled back to that, okay? We also considered, she's been on Enbrel for her rheumatoid arthritis, Okay, and there are very low rates of Enbrel causing liver enzyme elevations, but they usually aren't that high. They usually don't stick around that long. There are rare reported cases of Enbrel causing an autoimmune type hepatitis. But she had been on the Enbrel for quite a few years before presenting like this, and we thought it was less likely. Okay? Now, rheumatology thought the same thing too. We talked about this with them, and they said, well, maybe let's try something else, see if the liver enzymes get better. So they took her off the Enbrel, and they put her on methotrexate, another arthritis drug, and her transaminases, her liver enzymes tripled. So that failed. Okay, so you see the point. We're going through all different variations of things. So we tried that. That failed. Methotrexate went away. Back on the Enbrel. So sometimes when you're dealing with a disease and you don't know what to do and things don't fit right, sometimes sometimes it's wise to just give it some time, watch, monitor, and sometimes you just let the disease present itself. And what happened by now it's 2020, within about a year of this, so watching her for a while, 2020, she presents with overt jaundice, and she's hospitalized. Her bilirubin is 14 times what it should be, and her AST and ALT are now not just a little high, they're over 1,000. These are huge jumps, okay? And we do some more workup. We bring her into the hospital. She has a positive smooth muscle antibody, okay? And now her gamma globulins are elevated. So now she's got features looking more like an autoimmune hepatitis, like she's evolving from a PBC to an autoimmune hepatitis. Okay, and we check for viruses, and there are none, and we check for Wilson's, and there is none, and we do imaging to look at her bile ducts, and it's normal. So we say, okay, we think this is autoimmune hepatitis, let's do a biopsy. So here now she gets another liver biopsy in 2020, and what you're seeing here basically looks, smells, tastes, sounds like autoimmune hepatitis. So very severe inflammation, not just in the portal areas, but throughout the whole lobule of the liver. There's a lot of interface hepatitis. Remember, that's a very characteristic feature of autoimmune. Plasma cell clusters, lots of plasma cells, characteristic of autoimmune, okay? And because the inflammation is so bad, she does have a little bit of cholestasis, which is slowing of the bile flow. The fibrosis, fortunately, is still actually very mild, okay? It's actually showing stage 1 fibrosis, okay? So our FibroScan maybe overestimated things a little bit. Okay, and they didn't see intraepithelial Langerhans cells. That's typical of PBC. So they didn't see the PBC. They didn't see the florid duct lesions. So maybe the PBC is under control, and maybe now we're evolving to an autoimmune hepatitis, is what it looks like. And they do staining for some viruses. So now it looks like she's got autoimmune hepatitis. Okay, this is out of the textbook. These are the typical liver biopsy features of autoimmune hepatitis, and she's got a whole bunch of this stuff. I'm not going to belabor this slide, but she's got a bunch of stuff. It looks, smells, tastes like autoimmune hepatitis. So she is evolving to something else. Okay, so we diagnose her with an autoimmune hepatitis PBC overlap syndrome. Okay, it's a real thing. We didn't just make this up. So we treated her autoimmune hepatitis with steroids. We put her on prednisone, 30 milligrams a day. We continued the urso for the PBC. We continued the vitamin E for the fatty liver. And her LFTs dramatically dropped. So you could see, if you look at these numbers from 3 days, 2 weeks, and 2 months, after 2 months, her liver enzymes are basically normal, okay, including the alkaline phosphatase, which isn't even a hepatitis enzyme. But remember I said a lot of hepatitis, you get a little bit of cholestasis. So even her alk phos is normalizing. We are thrilled to death with these results, okay? Now, the problem now, because you know there's going to be one, so the problem now is she's on prednisone. That's a steroid. And long-term steroid use poses a lot of potential side effects, right? Obesity, bone thinning, diabetes, hypertension, facial changes, all kinds of mess. So you don't want to keep people on prednisone long-term. You want to transition them. You want to get the disease, autoimmune hepatitis, you want to get the disease into remission quickly with steroids, and then you want to transition them to another immunosuppressant medicine that is not a steroid that can maintain that remission over the long term and slowly get rid of the prednisone, okay? So that's the goal. You can imagine what's going to happen, right? Okay, so here's the next saga. So The prednisone was gradually tapered, and we made some efforts to eliminate the prednisone, okay? So what we usually use as a non-steroid immunosuppressant, first line, is 6-mercaptopurine, or 6-MP, also called azathioprine or Imuran as a variant. We checked this blood test to make sure that she didn't have a high risk of side effects to it, and that test was normal. So we put her on 6-MP. And the 6-MP dose, you do weight-based dosing, okay? And we start her on a low dose, 50 milligrams, and then go up to 100, and then go up to 150, which would be her appropriate weight-based dose. And as we're tapering the 6-MP up, we get her up to 150, which is our appropriate weight-based dose, and lo and behold, her numbers start climbing significantly. And we say to ourselves, okay, is this because of toxicity from the new drug, or is she relapsing because we're still tapering her prednisone? Okay, so those are the considerations. So what we do now is we take the 6-MP back down to the starting dose of 50, which she did okay with. We bump the prednisone back up a little bit, and her LFTs got better. Okay, and eventually they normalized completely. So we weren't happy with the 50 as a good maintenance dose because she was still a big gal. So we bumped her up to 100. We resumed our prednisone taper, and she stayed stable, but we could not get her off the prednisone. Every time we took the prednisone dose down to 20 milligrams, she'd be okay. Anytime we tried to take it down under 20 milligrams, her liver enzymes went up. Every time. So we could never get her down below 20. Translation, the 6-MP wasn't doing its job. So we had to come up with another plan. So we kept her on the prednisone 20 milligrams over for a while because, again, clinically she's feeling well. Her numbers are hanging out. We wanted to kind of give her just a little bit of a break from all the nonsense. And we talked about using another immunosuppressant called Cellcept, or mycophenolate, okay, which probably works at least as well as the 6-MP. There's less data about its efficacy, but the data is growing. I think it's becoming more popular in the liver world as a steroid-sparing immunosuppressant. But she was not interested in taking the mycophenolate, the Cellcept, because she was concerned about its side effects. So she put the kibosh to that. So we said, okay, she won't let us use this. The 6-MP isn't working really as well as we want. Let's try this thing, budesonide. So budesonide is a steroid. Okay, and what's special about the budesonide is when you take the budesonide, the steroid works in the gut, so it actually works good for like inflammatory bowel disease, and it gets absorbed by the gut and goes to the liver, and it works in the liver, so it's good for autoimmune hepatitis, but it gets almost completely digested by the liver its first pass through, so very little of the steroid gets out into the body to cause all those steroid side effects. So I said, hey, this sounds like a great plan. Let's switch you to the budesonide. That's a steroid that you're going to probably do better with, and then we can wean the prednisone because we don't need to double up on steroid. So that was kind of our plan. Okay, you think that worked? You should know better by now. So what happened? We put her on the budesonide. Okay, and within weeks, she developed this whole list of side effects: lower leg swelling, severe headaches, diffuse arthralgias. We stopped the budesonide; they all went away. So that's out. So at this point, her alk-phos is living between 150 and 200. Her AST is normal, but her ALT is like in the 40s and 60s. Not bad, but not perfect. And eventually, I kind of worked on her, and by December of 2022, she agrees to try the Cellcept in place of the 6-MP. Okay? Lo and behold, miracle of miracles, we found the right combination. So we stopped the 6-MP. We put her on the Cellcept. She has no side effects. Her LFTs within a few months normalize completely. If anybody knows liver enzymes, the bilirubin is 0.4. The alk-phos is 88. The AST and the ALT are in the 20s, completely, utterly normal. And then we said, great, now let's start tapering the prednisone. We actually successfully wean the prednisone down without our numbers going up. The prednisone finally gets stopped completely in the summer of 2023, and to date, since then, her LFTs has remained normal. She's also continued to be very aggressive about pursuing her weight loss, and she's now brought her weight down to 192 pounds, almost 60 pounds down from her maximum weight. Okay, so to date, her LFTs remain entirely normal. Her treatment regimen consists simply of the urso, the CellCept, and the vitamin E. We did a restaging FibroScan in 2023. She had no significant fibrosis. She had no significant steatosis. In 24, we did a bone density scan, which is still normal in spite of all the prednisone she'd had in the years previous. The most recent labs in February of this year, blood counts normal, blood chemistries are normal, LFTs, as you could see here, are eminently stone cold normal. So I promised you a happy ending, and there it is. So one last quick slide I have. Autoimmune liver disease variants or overlap syndromes are not, again, these are rare diseases, and this is kind of a weird manifestation of a weird disease, but if you're a liver doc, you will occasionally see these. Overlap syndromes are people who have features of different autoimmune diseases. So I call it a Chinese menu diagnosis. Okay, one from column A, one from column B, one from column C. So instead of meeting the strict diagnostic criteria for PBC, or the strict diagnostic criteria for PSC, or the strict diagnostic criteria for autoimmune hepatitis, okay, you have features of some of this, and you can have overlap of any two of those. So it can be an autoimmune PSC, autoimmune PBC, PBC PSC. You can have overlapping of this, and about 18% of patients with autoimmune liver disease do have overlap features. So it's not terribly uncommon. I wouldn't call it rare. For diagnosis of autoimmune hepatitis, there's this international autoimmune hepatitis group that has a scoring system, just like Dr. Susky was showing for Wilson's disease. There is a scoring system for autoimmune hepatitis. Unfortunately, that's not really valid or useful for these overlap syndromes, so the diagnosis can be very challenging, as you can imagine. The features of these different diseases can, and that's the other weird thing, is they can present together at the same time, or they can present at different times altogether, just like Our Lady here did. And frankly, it can present at any time. So you can go on looking, smelling, tasting like PBC for years, and then develop features of another one of those diseases. So these are challenging. These are challenging. And again, the treatment, there is treatment. Treatment is generally directed towards what is histologically predominant. So what is predominant on the liver biopsy is what you should really target. Does it look, smell, taste more like autoimmune hepatitis? Does it look more like a cholestatic disease? And in many cases, we actually end up using a combination of treatments. So we'll use urso and steroids, just like we did in our young lady here. So if you're not exhausted, I am. I think we're all done, exhausted. I thank you for attention at the end of the day. Thank you again to the CLA and Susanna for inviting me to speak. It was a pleasure. Thank you.